Good evening, and welcome to the Senior College course Hospice. This is the final course of the spring 2024 semester, and I'm delighted to see such a wonderful turnout for this important and insightful class. Today, we have the privilege of learning about the invaluable role that hospice care plays in easing the burdens felt by those nearing the end of life and their families. Our esteemed instructors will dispel common misconceptions and provide us with knowledge and tools to be a part of a team dedicated to improving the quality of life for our loved ones during their final days. First, we have Jane Ryu, RN, a graduate of St. Mary's School of Nursing in 1985. Jane has been with Northern Light Home Care and Hospice since February of 2016. Her extensive career includes experience in the emergency department, med-surg, telemetry, the MD office, ED supervisor, nursing administration, and now hospice care, showcasing her versatility and commitment to patient care. Next, I'd like to introduce Christy St. Peter, OTRL, and I apologize if I get the alphabet messed up. BCG. Christy graduated from the University of New England and has been an occupational therapist for an impressive 27 years. She has dedicated the last 8 years of her career to Northern Light, where she brings her expertise and compassion to those in need. Our third instructor is Gail Fairkirk, who graduated from the University of Maine at Presque Isle in 2003 with a Bachelor of Social Work, and from the University of New England in 2006 with a Master of Social Work. Gail started with Northern Light Hospice in 2002 as a volunteer and was hired as a social worker in 2003. After a brief hiatus, she returned in 2012 to continue her vital work. Gail has been the manager of the Aroostook House of Comfort since its opening in 2018. Finally, last but certainly not least, an old phrase, Carrie Thibault, who has a background in nursing that includes a graduate from UMFK in 2008, time as in med-surg, ICU as a nurse for 7 years, director of medical practice in the provider's office, and is now doing provider relations for Northern Light. Please join me in welcoming our distinguished panel of experts who will guide us through this journey of understanding hospice care, its significance, and how we can support our loved ones during this critical time. Let's begin this class, and if you have questions, don't hesitate to raise your hand and ask them. I'm sure that we will be able to answer. Thank you.
So we'll do an overview of home care, hospice, and House of Comfort. And first up, I'll ask Jane to come up and present on home care.
You're going to be the...
I'll be the
Yay, thank you. I know I was introduced as working with hospice, and I am a manager for home health, but we do work very closely. The three managers work real close together because our programs do intertwine. So home health is, our focus is not to, sometimes when we go into homes, people will think our focus is to get them to go to a nursing home. That's not what it's about. Our focus with home health is to help people be home, live independently, and be safe doing it. And we are with people for a period of about 60 days to evaluate. It takes us that long to be able to determine what people need and how we can help them in their home. So our focus is quality, it's recovery, it's to be safe, it's to help them get connected with the services. I like to think that our person is in the middle, our patient's in the middle, and we are the people that help them navigate. Some people have several providers that they see, and we kind of help them connect that because it can get really overwhelming, especially for our elderly who may have specialists all over the state, sometimes out of state, and they just get real overwhelmed real quick, and it's kind of our job to help connect all of that together. Next, okay, this is a big one. How many of you think that because you have home care, you can't go anywhere? Right? I've heard that over and over and over again, but I'm not homebound. Well, homebound it's hard to explain, but these are our definitions that CMS or Medicare tells us we have to follow. So somebody who is homebound needs to have supportive aid. They need special transportation to leave their house. So somebody who has a home that is in need of a lot of repair, and they may have a lot of chronic conditions, and their stairs to get out of their house are not safe, and so they stay home because they can't get out of their house, that's one reason why they're homebound. They can't get out of their house. They have a condition that makes them, it's contraindicated that they leave home. So maybe somebody with a big wound that we are taking care of at home, or maybe it's somebody who's had orthopedic surgery and they have a lot of external hardware and they really can't be leaving home. That is another reason why someone's homebound. There has to be a normal inability to leave home. You're a person who has agoraphobia. They're afraid to leave their house. That's a reason for being homebound. They panic when they get out into the world. Leaving their home is considerable and taxing. People with lung disease who really struggle to leave the house and they get short of breath, they can't walk 10 feet without having to sit or rest, or that's taxing on their body. They are homebound. I've had many a conversation with people, but I want to be able to go to have my coffee in the morning. That's the only time that I can get out of the house. But when they get back home, they're sleeping the rest of the day because they're exhausted. That's a reason for homebound. So really, homebound status, it's our job to document that really well so the insurance doesn't say, oh, they're not homebound, you can't go anymore. So the responsibility falls on us to really document clearly, and Christy and I meet with clinicians all the time to make sure that their documentation supports somebody being on home care. Any questions about that? It's a lot. Even sometimes we're like hard to make it work. Sure.
How does a patient get referred to you? How does someone come under your
provider?
Their provider, okay.
Yes, your provider or the emergency room. I point to Janine because we worked together for a long time in the emergency room. But it has to be a provider. It could be a nurse practitioner, a PA, doctor, but it has to come through us, through a provider. Who works for us? What kinds of people work for us? We have registered nurses. And we have registered nurses who work with our telehealth program. They're certified in heart failure. We have wound, ostomy, and continence nurses. So we're fortunate in Aroostook County. We have 2 nurses who went for specialized training for wounds, ostomies, and people with continence issues. Geriatric certification. Christy is certified in geriatrics. And some of our therapists, our PTs and OTs are certified. We have a certified wheelchair specialist, and she will go out and evaluate and help people get a wheelchair that works for them. It's amazing how many people have old wheelchairs and they're getting pressure sores because they're not fitting in their wheelchair properly. So that's what she does. We also have a physical therapist who is training. She has 2 more certifications in pelvic health. And so people with incontinence issues, she can help them strengthen their pelvic floor muscles so they don't have those issues. Our team. So in home health, our team consists of skilled nursing, so that would be RNs and LPNs, home health aides, and our home health aides are CNAs. They have to, in order to work in home care, they have to go through a little bit more training to work in home care because our home health aides can draw blood in the home. They can do some simple wound care in the home. So, and our home health aides do a lot of traveling. They work all over. We have physical therapists, occupational therapists. speech language pathologists or speech therapists. Right now we're recruiting for somebody. Social workers, wound care, chronic disease management, and telehealth. And Carrie's going to talk a little bit about our telehealth program later, but that is really taken off for us. We don't have a palliative care. Northern Light, originally palliative care, which Gail will talk a little bit about later. It's kind of a cousin to hospice. Our system has moved a palliative care program to our hospitals, but we work closely with our palliative care providers in home health. So what does a nurse do? We visit our patients on a regular basis. We also provide on-call services. After hours, we always have a nurse that's on call, so if somebody's having a problem with pain or symptom management, we all take our turns and be on call, and we'll go out anytime, night or, doesn't matter. When we're on call, that's our role. We assess for pain, infection. We help people with medication management. We do a lot of teaching in the home. We talk about nutritional status, bowel function, safety, and psychosocial concerns. Best patient visit is when somebody's at their camp and we get to sit outside. It really is, except for when all the caterpillars are around. We do a lot of education with patients and families. We will do IV therapy at home. We do total parental nutrition at home. We've had patients on ventilators at home. What else? Pediatrics.
How about dialysis?
Peritoneal dialysis at home. I have a lot of wound vacs, so people on with a big wound and they have a machine that is helping to heal their wound. I've done more of that than I did in the hospital setting. When we're hiring new nurses, I tell people we work in a small rural hospital and we do a lot. But those sick patients get sent somewhere. And where do they go when they are sent home from the hospital? They go home, and we're doing that at home. So we do a lot in the home that people don't realize. And we teach families to do that. We teach people how to give their own antibiotics, how to give their own TPN, how to suction. We teach all of that, but we support people to do that. We supervise our nursing assistants, and we work with the patient's doctors or providers closely to make sure that the patients are getting what they need. Our home health aides, like I mentioned earlier, they are going into the home. They are helping people with personal care. We want people to be independent and safe, and sometimes when people are really sick, they don't have the strength to do that, and that's what our home health aides do. They'll go in and help them until they can get to a place where they can do that by themselves. They help with changing beds. It's to make the patient comfortable. They do not do house cleaning. And a lot of people are like, well, I don't need that. I just want someone to clean my house. Well, we're there to help them with personal care to get stronger so they can clean their house. Christy, you're up.
Jane, just a quick question. How many patients do you have, like, per nurse? How many patients?
Per nurse, well, we like to keep it around 25. Some people have more, depending on where, like a majority of our patients are in our central area, because AR Gould is our system hospital. But we do have, some of our nurses up here have 20 patients, so it all depends. It waxes and wanes.
Yeah. Okay, thank you.
Spinning off of that, also, our geography is quite large. So Northern Light Home Care and Hospice covers most of the state. There's a few pockets of the state that we don't cover, but for Aroostook, we cover from the Allagash all the way down to Benedicta into Penobscot and Washington counties. So we see patients, not always, goes in little spurts, but up into Princeton, Vanceboro even.
Danforth.
And Danforth, yeah. So our clinicians stay very busy. So going back to the types of services that we offer, physical therapy. Our therapists for physical therapy tend to focus on improving people's mobility, prevention of falls, help them get stronger. We have some therapists that are also dabbling with vestibular therapy, again, ways to prevent falls. That's becoming more increasingly common. So that's something that they're able to help with. We also want to, they're also going to assess, but in addition to physical therapists, we have physical therapy assistants, and they work very closely with each other so that we can help our patients meet their goals. Sometimes as a therapist, we go in, we evaluate, and I may have a plan for you, but that may not be what you want. So we do work with our patients to meet their goals. They might just have a goal to be able to attend someone's graduation, and that's what they really want to strive for. So that's what our therapists will focus on. We have occupational therapy, that's me. I went from a setting of hospital to home care, and that transition opened my eyes. It makes sense. As a therapist, if I have a treatment in mind and it's not working out, I usually now from the home setting can see why. I remember distinctly thinking a person needed a shower transfer bench. You're going to be able to shower so much easier having this device. They went and got it, came back and said it doesn't fit. Well, they're adjustable. They have to fit. But now that I was in the home setting, I understood. I could see the setup and why things weren't working. So now the recommendations make more sense. As an occupational therapist, we're about independence, trying to teach people to become more independent and, again, working with their goals. What is it that we can help to modify their environment or teach them to help them do better? We also dabble with cognition. And I say dabble because that's an area where us and the next slide, please, speech therapy also, we kind of commingle in those areas. So this is one area where OT and speech work together to help patients that might have some cognitive impairments. It could be very mild. And then as it gets to be more complex, that's where the speech therapist ends up having a little more knowledge on. But with the speech therapist, I think a lot of people are familiar with the articulation piece of speech therapy. They're familiar with maybe the swallowing components that a speech therapist can help with. If someone's had a stroke and they're going to have a harder time maybe with their swallowing, a speech therapist would help with that. But they also have other treatments that they work on to help stimulate weaker muscles. There's a particular treatment that they do, and it's a specialty. We don't have anybody with that, as Jane said, we're recruiting, we're getting closer, but it's a field where there's not a lot out there right now. So we're working actually, one of the other wonderful things about technology is that another office that we have, they have a speech therapist. So we're collaborating with that person to help bring the service to our patient. And this is Gail. Doing a round robin, we'll be back.
For social work, sometimes it's very challenging to get a social worker into a home, because the first thing that people think of is that we want to see the skeletons in the closet, we want people to air their dirty laundry, we want to be really nosy. Well, that's not the case. There are so many questions that come up, and when people come home from a facility or a hospital or whatnot to come home, there's things that they might need. And one of those things are additional resources in the home to help keep them safe at home. They might need additional services such as long-term care, not in a nursing home, but in their home. So we go through that and we talk about what that is. You know, do you need help after home health has discharged them? Do they need additional or ongoing care for personal care? Do they need a ring because things have changed? If they've gone to the hospital or if they've gone to a nursing home, they've had some sort of an event and they might need a ramp. So social work will navigate those resources out there for you because it's very complicated. And then it comes down to the question of who's going to pay for that service. Well, growing older sometimes comes with challenges. And obviously, not everything is free. Medicare doesn't cover certain things. They'll cover your home health in the home and all the therapies and all the disciplines that Jane and Christy had discussed. But at some point, you're going to need that additional care. It's like long-term care in a nursing home. That's not free. Medicare does not cover that. It does under skilled, but it doesn't cover it on long-term care. So who pays for that? So that's part of the service what social work does, is they try to navigate that for you. It may not be you, but it might be a family member that you're helping to care for. So we will navigate that. We'll talk about main care and what that means, and what the threshold is, what the payments are. We'll help you with the applications. We would look to see if somebody's a veteran, and do you have long-term care insurance? And we look in the resources that you have within your community. This is the day and age where things are getting very scarce. And so let social work do that for you. Let us do the legwork. Okay? We'll reach out to whatever services you have in the area or within the county and go from there. That's why it's very important to let us know, are you a veteran? Do you have that long-term care insurance? You'd be surprised that some people have it and they forget about it. Well, you know how you forget a long-term care, because it's super expensive. But it's a good tool to have. So think about that. We work to try to find out what your coping mechanisms are. You know, if you went to the hospital and you came back, you might have, there might be some depression, there might be some frustrations. You're not the same as what you were. Some people lose a limb. You know, that's grief and loss right there. You're grieving. Are you a new retiree? Are you, do you have to sell your home and go into assisted living? So there's things like that, that it's not just the physical components of what you're dealing with after returning home from a hospital or nursing home. You're dealing with the bigger picture, and it's all that emotion. As we get older, obviously we have more limitations. And maybe it was an event that created that. Was it a heart attack? Was it a broken hip? Regardless of what it is. So let us, the social workers, help navigate that for you. And let us talk about it. We don't need to know your deep, dark secrets or anything like that, because that's what people think. They're like, no, I don't need anybody nosy in here. No. We want to help you navigate what your strengths are and what you have for supports. Who do you have around you for family support? Do you have a church support? Do you belong to any groups? Things like that. So that's what social workers can do as well, along with looking at what the finances are. There's a whole sea of information out there, so it's not just, you know, we're a valuable piece to the complicated puzzle, let's put it that way, okay? What we can't fix are long-term care dynamics. Like, we've had staff will come and say, oh my God, they are just yelling at each other. That's not going to change when we walk in. We can't fix long-term care long-term behavior. You know, we're not going to change it that you guys don't scream at each other anymore. That's just relationships. And everybody has to realize that every relationship is different. We're not there to judge. We're there to work with what you have, with what you're willing to do. If you want to yell at each other, go ahead, yell at each other. You know, we can't make your children come and be with you and care for you. They'll be surprised at the amount of patients that we have that do have family within the area, but they're not able to support, but they're not able to support for certain reasons. Some reasons we don't understand. But that's where we pull back our judgment. This is not about us, this is about the patient goals. So we try to navigate that. But we're not going to change things. We can help try to find out what we can do to help find the support and find out what you're able to do to cope with your change. Could be that, you know, you're not able to ambulate as much. You're not able to go for your 5-mile walk anymore. It's trying to navigate that so you're working with small goals to reach your big goal. Okay? And the other thing that we work with is we try to support our team as well. There are some situations that we go into that may not be safe. Depending upon the home, depending upon the dynamic. We're living in a world of lack of resources, drug use, substance use, and we try to work with people with that as well, okay? But we can't change people are allowed to make poor choices. put it that way. We have worked with families and patients who may have a slight cognition issue, but they're still able to make their own decisions. And the state of Maine will say they're able to make their bad decisions. So we're entitled to do that. We may not agree with it. And that's where we kind of work with as a team too. It's like, hey, Christy, I know what you're saying, but they're able to make crappy decisions. We all are. People may not agree with it, but there are decisions. And there are times, yes, that we have to get adult protective involved or child protective involved. We don't do that easily. We do that with a lot of discussion. We work with the families and say, listen, Grammy's not able to stay home anymore, and this is why. Leaving the stove on, leaving the door open, giving your financial information over the phone. That's not safe. And so we also work with the provider too, just to say, you know, they're really not safe driving. We're not going to take your license, but we're also that caveat for information too, to help keep somebody safe. That's our goal, is we want patients to reach their baseline. We want them to get better. We want them to be independent, but we also want them safe. So that's what social workers can help with as well. Any questions? Yes.
Medicare would pay for like wheelchairs and all that stuff. That'll be long.
Not always.
You want me to take that?
Yeah, you take that.
So, any DME, we call it DME, wheelchairs, durable medical equipment, so wheelchairs, I'm even going to go as far as walkers, canes, things like that. So, the big thing that we've come across, everyone's familiar with Medicare. You guys have seen the advertisements on TV. There's a lot of Medicare Advantage plans that they're pushing out there. They're cheaper. It's a lesser copay. You'll get free stuff. The thing for the standard, I'm going to say the gold standard for Medicare, and I'm going to say the primary typical Medicare program. They'll pay for a device. They'll pay for a wheelchair. They'll pay for a person to get worse. And it's every 5 years. So, the same as Jane has something happen, she needs, I'm just going to say she needs a walker today. Sorry, Jane. You had your knee done.
I'm the fall risk one. I'm the fall risk.
That's true. So she had her knee done, she needs a walker now, and her insurance will pay for that. In a month from now, something else happens, and now she got a bad infection. We don't wish that upon her, sometimes it happens. Now she's going to be off weight bearing, she needs her wheelchair. Her insurance will pay for that too. But let's say she goes to that walker, now she's getting better and needs a cane. Nope. So it's weird, right? So it depends, I'm going to say specifically, it depends on your insurance for what's covered. Main Care will pay for additional items that Medicare would not, but it's very specific to the type of policy that person has. Any other? Yeah, go ahead.
It depends on what financial bracket you're in, correct?
Nope, it depends on your policy. What your income is or your financial bracket has no bearing on your insurance policy.
Not the insurance policy, but Medicare and Medicaid.
Oh, I'm not a Medicare expert.
Well, if you're in the middle, let's be honest, if you're in the middle class in this, in Maine, it's a lot harder to get any of your service.
So
You have to pay.
our services, home care
Because you're on a
hospice.
social bracket, correct?
No. So for home care hospice, Medicare pays, and I'm saying a traditional Medicare plan. The Advantage plans, kind of put those out of your way right now. A traditional Medicare plan is covered 100% as long as you meet the criteria for homebound and having a skilled need. So those are the two big parameters for qualifications under home care. Hospice is a little different. I'll have Gail explain that. So, yes.
Now, have you been dealing with a lot of scams? Apparently, patients are getting phone calls and saying you're having back pain.
Yeah.
And you know you qualify for a back brace for free.
Yes.
And then they give their insurance.
Yep.
And then the scammer collects the
whatever.
money. Are you seeing a lot of that?
We're seeing some of it. And when we hear of the scams, so our local police departments and sheriff, they're very good about putting out, alerts out on, I'm going to say Facebook, the social medias, TV, to let us know there's a particular scam that we can be aware of. So when we hear and see of those, we let our staff know so they can let our patients know. We do try to keep them informed, and as we're working with people, we see the vulnerable. Those that are the hardest to, hard to hear over the phone, they get really mixed up because, one entity, I'll use my husband as an example, and this has nothing to do with hearing. He's doing a project, so he had to see the bank. Well, we're getting all kinds of letters, and it's about mortgage, your mortgage, your mortgage. It's not even from the bank, but somebody unknowing wouldn't realize that. So between the mailings and the phone calls, our patients get inundated. Absolutely inundated. And it's hard to know what's real and what's not. So really, we just need to keep talking about it and telling them, don't give out your information. Do not give out your date of birth. Have somebody with you when you want to make a phone call back. Good questions. I know that was kind of grim, sorry.
But it's true though, because, especially our elderly, they're vulnerable.
Yeah.
And if people don't know, and sometimes we get alerts from our leaders to say, hey, this is going on, and we go out and we make sure our patients are educated so they don't get scammed.
Yeah.
It's sad, actually. Any other questions about that? Sure.
For you people to provide services in a home, is it the primary doctor that refers it to you, or is it the family after a patient is at home that refers?
We have to have a referral from a provider, so it could be a nurse practitioner, a doctor. It could be if somebody goes to the emergency room, we get referrals from there. It has to be a provider because there are certain criteria that insurances require us to report, and that has to come from a provider. So it needs to be a doctor or a nurse practitioner or a PA or the emergency room.
But is it usually done in the facility of the hospital before you
Yes.
go in?
So we get referrals from doctor's offices, from emergency rooms, from hospitals. Yes. Sometimes we get calls from family to say, how do we get your service?
That's right.
And we'll just say, you need to call your doctor and have them make a referral to us.
Thank you.
Wound care. I talked a little bit about our wound nurses, but these are all the different treatments that our wound nurses work with. So people with diabetic ulcers, venous stasis ulcers, leg edema, they work with that, acute and chronic wounds, chronic skin and wound infections, ostomies. We have a lot of people with new colostomies or urostomies or ileostomies. Our wound nurses work really close with them. Continence disorders, pressure injuries, fistulas, or non-healing surgical incisions. They're really educated and they're really good. And we rely on them. We have a wound team. So we have wound nurses in South Portland and wound nurses up here. The middle, we don't have anybody yet, but we're working on that. And we have a system that we use photographs, and we will send pictures to our wound nurses, and they'll make recommendations. We work closely with wound clinics and providers to provide wound care. You're next.
It's back to me.
It's Jane
Sorry.
still.
Is it Jane?
What?
Telehealth?
It's you.
Oh, that's
That was my name.
Oh, sorry, I don't have, no.
It's okay. It says me. So a lot of people have heard about telehealth. I think with COVID, we've all learned a lot about telehealth. Because people weren't able to go see their doctors, this was brought more to light and more available. We have telehealth, but it's a little different than what you're thinking of, most likely. Most people think about telehealth as a way to communicate with their provider. For us, we have a telehealth team, which consists of nurses that are specialized in the cardiac, the respiratory systems. And so they act as case managers for our patients. So a lot of these respiratory illnesses, people that would qualify for our telehealth program, we say CHF, congestive heart failure, COPD, somebody who's had a recent heart surgery, blood pressure issues, someone might be having some medication changes. There's a lot of different diagnoses. There's a long list, actually. Those are the common ones. Oh, and also anyone that might be experiencing a weight loss. So, I have a show and tell. This is our telehealth unit.
And this is not an extra charge either. This is something
Right,
that
yeah.
we provide.
Yeah. So when someone comes on to service with us, you guys see in the back? So when someone comes on to service with us, the first person that goes in to assess the patient, they're looking at their diagnoses, and they're also looking at their function. And so we always talk with our patient, their family, would you be willing to have telehealth? Our nurses that are behind the scenes, if they say yes, we're going to install a scale, which is going to pair with a tablet, blood pressure cuff, and an oximeter. So our nurses are going to be monitoring their weights, their blood pressures, and their oxygen levels every single day. And if any of these measures go out of the parameters of what we want to see, our nurses are going to call our patient, hey, can you recheck that for me? Your blood pressure was a little high. They might come back and say, well, the therapist was just here. And if that's the case, that's fine. We're going to recheck it. So we do have that checks and balance. We work with our providers, or with actually the patient's providers. We get protocol medications to help. Our goal, again, is to keep people home. So these medications are specific to their disease. And it would help. Sometimes if someone's having an increase in their weight, they might increase the fluid pill a little bit. We get these doctor's orders ahead of time. We have the medications in place and ready to rock and roll. That way at 4:30 on a Friday afternoon, when all the doctors have gone home, we can get this going. Keep our patients home.
So Christy, some of those meds are like IV lacings. We can give IV lacings at home.
Yeah.
Yeah, things like that.
Antibiotics for the COPD folks. Yeah. Oops, sorry.
Do you want me to
Go back just a second, I'm sorry. There we go. Let's see. So we're going to teach people how to use the equipment. We're going to help them with that. Okay, I got paper. I just want to make sure I don't miss anything here. We're also going to work with medications, teaching the patients how to use their medications, because sometimes the problem isn't just what's added, but just their regular medications. And so, especially for cases where we might just have therapies only, it might just be a physical therapy and occupational therapy case with no nursing involved. And these telehealth nurses can help us with that education of those medications. It's all about getting a better understanding of their health. The other really grand thing that we utilize this for is for the telehealth component, the video part. We've been able to prevent people. So again, we have patients all over, and we've had patients in Danforth, for example. They went home from surgery. They had like a knee surgery. Therapist went in. The incision's not looking good. We videoed with the provider, which saved them from having to go 2 hours for an office visit, made recommendations, ordered a script, and the patient stayed home the whole time. And it was really wonderful. So the collaboration, having this unit set up, has been really phenomenal. We've also been able to use it, this is every day, so on the weekends, when there's less staffing around, telehealth team is still available. So we've had phone calls to or email, we use a lot of email, to our telehealth team to say, hey, I'm worried about Miss Jane. She's starting to have a little more shortness of breath. Can someone call her over the weekend and just check on her, make sure she's okay? And they do. It's just an added layer. The big focus, again, reducing rehospitalizations. Okay, now you can go ahead. Thank you. So what does telehealth do for you? It's going to keep your care team updated. So of the staff that are seeing the patient, we get to see these results too. So we also can then, I'm noticing your shortness of breath is getting a little worse. How are you feeling today? We can focus in on these pieces. It can remind you to take your medications. These, we have some new iPads. Well, they're not iPads, I'm sorry. Tablets. And there can be prompts to take your medications. If you have diabetes, you can enter manually your blood sugars. So there's different questions that this will ask you, and it's just to keep kind of tabs on your health in a good way. Again, we can call the provider. So let's say that someone's going to see their doctor next week, and the doctor wants to know what their blood pressures have been. They can send all of the trends. That way the doctor knows ahead of time kind of what's been going on for their patient, whether any medication adjustments need to happen. And again, the big thing is that last component here, detection. If anything is going awry, the care team is going to know sooner than later. So what makes Northern Light different? We have telehealth. Not everybody has this. I think we're the only home care agency that does offer this. So this is really phenomenal. It kind of sets us apart. Over 500 telehealth monitors are installed in patients' homes statewide. We're working on increasing that. We got a grant, I believe we got approval for a grant to increase that number significantly, which means that's even more patients we can help. Patients that have the CHF clinic, they're, sorry, I had to think about it. So in Presque Isle, there's a CHF cardiology. Yeah, cardiology, thank you. And so that's why it takes a team. So even at the end, when home care is done, we're ready to discharge you. If you're part of that clinic, you can keep this stuff. They continue to monitor. Again, another added layer. It's free.
And it's not just for home care too. We can also use it for hospice.
Yes.
So if there's ever.
Yeah. And there's just some patients that are a little higher risk than others, even if they're not associated with the clinic, or, we talk about it with our telehealth team. Hey, do you think we could keep that in a little longer? And sometimes we do, Let's see. Okay, so along with this, every day, I talked a little bit about the questions. We call those survey questions, so that's what that is. And then, let's see, reducing rehospitalizations, assessing. Is there anything else that I missed on that? I think that
It was helpful during COVID.
Tremendously. Tremendously. Yeah.
And even right now, we have that patient that's going to be doing palliative care that can't get to the provider's office, so we're going to have our nurse go in,
Yes.
while the palliative doctor's seeing the patient, so they can have that combined.
Yeah.
They know what they're talking to the provider with and stuff, so we're all on the same page. That'll be
And
nice.
this is also the same. We're not going to use a scale, but for that patient that we need speech therapy for, a Bangor therapist is going to help us with that. We can use this tablet. It's really, really wonderful. So I guess there was one more for me here. Our success story. We've been able to demonstrate a reduction in our hospitalization rates by having telehealth installed. Just in that first year of our having the heart failure program. Our 30-day rehospitalization rate reduced by 8.6% compared to 15.9 on the national average, so that's significant. And then also in one 30-day period, only 4% of our 380 telehealth patients were admitted, which is comparatively a low number. Sometimes we can't prevent those hospitalizations, but we do try our best. So we talk about orthopedic surgeries. We get actually quite a bit of patients that come to us following surgery. And it could be hips and knees, those are the most common, but sometimes we also have patients that come to us after shoulder surgeries. We work as a team, and I think Jake can attest to this, just from our past experiences in working different places. Northern Light Home Care Hospice is the most collaborative team because we don't work in silos. I'm an OT by trade. I go into a home, I might be the only person the patient sees that day. So if they're having medication issues, as long as it's within my scope, I can work with them. If not, I know who to call. We can always help the patient with their needs. Sometimes I might put that social worker hat and be making a referral for Meals on Wheels. Sometimes I might be, did you do your exercises for that physical therapist today? And just kind of help them along. So we work together as a big team. By having that collaborative effort, we reduce anxieties for our patients. We help with their pain management. Again, with the wound care, if there's any incision issues, we work with them on that. Nurses, a lot of times a patient will come home with a nurse for the medication piece, for the bowel piece, making sure things are working good, and for that incision care. Our therapists, all of our staff, we utilize everybody to the top of their license. So that might mean that a physical therapist might remove your staples, not your sutures, but your staples. The PT might be taking your INRs to see how thin your blood is. So, and as Jane said, our home health aides can do phlebotomy too. So there's a lot of things that we have that we can bring to the table and develop a care plan that meets your needs. And this is your...
I'm next. So I'm sure you all have heard of Life Alert in the past. Just like we have the telehealth units, we have something that's called LiveSafe. And that's something that helps patients and family members feel like their loved ones can stay home more independently. It helps with falls, if they have a fall, or if there's anything medical, fire, or if they need to call the police, they press a button and someone will be on the line and kind of triage as to what help they need. We work closely with Connect America to make sure that our patients can be as independent as possible. I say our patients, but they do not have to be home care or hospice. Anybody, they don't have to have our services in order to get them. So it's easy to use. You have the around clock monitoring. There's no hidden fees or equipment charges. No long-term contracts, and whenever they press the button, there'll be the two-way voice command. So they'll question you, they'll hear you speak, and then you guys can have a conversation just like you'd be on the phone. So there's different types of devices that we have. We have the Homeland and cellular system. So that's a bigger box, and I do have some demos if you guys are interested after, but I have like 6 different ones, so I'm going to take them all out. But we have the bigger boxes where it connects into your landline. No, a lot of people don't have landlines anymore, so the cellular one and the landline kind of look the same, but one has the plug-in and one doesn't. You have the two-way speaker. You also have either the wrist or the necklace that you can put around. You can also have an option for the fall protection, and there's the battery protection. So for the cellular features, you don't have the landline, and you do not need a cellular phone in order to do this. It bounces off the towers. It works with AT&T or Verizon, and like I just mentioned, you don't need a cellular contract. So then there's also on-the-go mobile LET, and so that is nice because it has the GPS technology, so that way if a loved one is out and about, you can kind of keep an eye on them. Same thing, you have the two-way loudspeaker, press the button for help and you can have that communication. They're pretty much all the same, I'll just go over them real quick, but for the most part they have the same options. Works with AT&T and Verizon, same thing, fall protection or detection. You don't need a cell phone or a landline. You have the device, you can use the neck or the wrist, and what's nice with this is the wrist and the neck can be worn in the shower. And this one lasts up to 5 days. What we're looking at is this one is quite clunky. So when you're wearing it, it's quite big, but we just got some new ones that they're starting to slowly put out, and they're probably about half the size and half the weight, which will be nice for the elderly when they have that around their neck. It's quite heavy.
Because they take it off.
Because they take it off, they don't use it.
They're hanging on the bedpost.
Are there any dead spots with these?
Yes.
Yes, so it's Verizon, AT&T, so kind of the same thing, like if you have those dead spots and stuff. But what's nice is I learned this with Carla, who does, she does the LiveSafe and stuff. If someone goes to Florida, they can still bring it to Florida in the wintertime. So you know what I mean, as long as there's service and stuff, it works well. And then there's on-the-go bell. So no landline or cell phone required, same thing. It's just pretty much, for the most part, the device looks different. This one actually has a 30-day battery life compared to the other one only had the 5-day. And they're actually talking about getting a nice watch, so kind of like a smart Apple Watch. That's the next step that we're looking at as well. So just quick, we have the 24/7, 365, anytime that you guys call, we would be available. Over 35 years of experience. Like I mentioned, nationwide service, so it doesn't matter where you're going on vacation as long as there's service where you're going. We're able to keep that up. What's nice is there's 140 different languages. So French, if we had French speaking, that's great. And then notifications to the emergency responders, caregivers, or loved ones. So this is just nice to be able to have your loved ones or yourself be able to stay at home and kind of still have that independence, but not have to worry as much. So we just put a couple positive things. So what happens is we end up sending out surveys to a majority of our patients after they have our service, and James, speak up if I'm saying this wrong, but after they have their services with us. And they're able to comment positive or negatively. So we ended up putting a couple of the comments that we ended up just having recently on some of our surveys. So one of them was, if it weren't for home care, I wouldn't have continued my care at all. I'm so grateful for the team that comes to my house. I always get questions answered. I really enjoy having a visitor too. A lot of times our elderly don't have people that come into their houses, so as soon as you walk in, they have a big smile. It's like we end up being family members of them after, yeah. I've grown to really love my physical therapist and our aide. I really miss them once I will really miss them once I am healed. I find myself lucky to have some very good nurses. Some are very special, caring, concerning, and clean, and knowledgeable, and hoping for progress. We ended up having one of our patients not too long ago that was having services up here, and she ended up wanting to go down to Christmas and having an appointment with a provider down in southern Portland. So since we cover from Aroostook all the way down to South Portland, we were able to work closely with our people in South Portland to still let her have her services while she was with her daughter for the week. So that way she didn't miss anything while she wasn't at home. So that's something else that's really nice, that we cover the whole state of Maine.
All right.
Perfect, now we'll talk about hospice.
Okay.
Tell me next slide if I'm not on.
I'll tell you, Vanna, when you have to turn. So with hospice, hospice is a philosophy of care, and it's for those individuals. I'm going to try not to do that because I've done this so many times. It's designed for patients who have been given a terminal diagnosis from their provider and a prognosis of 6 months or less. I don't want to say this right. Now, what does that mean? That just means that's Medicare's version of a guide to go by. That doesn't mean at 6 months time is up, okay? We've worked with many patients before who really took that literally. And because when they're seeing their provider, that's all they've known. They have a lot of trust in their provider. And so when the provider will say, you have a few months, 3 months, or 2 weeks, people do not go home to live until they die. They go home to die. That is two very different things, and it's a different way to look at that. That's going to determine a lot of your quality of care. So in hospice, there's nobody in this room that's going to get out of this life alive, right? That's going to happen. Now, what we try to do when people are given those prognosis and those diagnoses, we want to make sure that you're living the best that you possibly can. Okay? We don't prolong under hospice. We don't speed it up. So we are going to talk a lot about the myths that you've heard, and we're going to talk about anything else that may not be on here. We work as a team approach, so we do work along with the same disciplines that under home health. There's nursing, there's social work, there's home health aides, we have chaplains, we do have therapies because we want people to be safe, so if we need to have them assessed for transfers or mobility, anything like that. So we go based on what the patient's goals are, not what our goals are, okay? We also have volunteers that can kind of be with the patient too if somebody has to go and run errands. And after hospice, after the patient has died, we do follow the caregiver, family member, or whoever is involved in the care. We do follow them for 13 months after, because that's a lot when the reality kicks in. You know, things are very, very busy. There's a lot of people involved in hospice. People are coming to your home, or it could be in a nursing home or wherever home is. But once somebody dies, after the funeral, there's silence a lot. That's when everything, your mind starts going. So that's why we follow people for 13 months. If they want to, they can tell us, no, don't call me again, don't send me anything. So we do respect that. But what we do is we try to encourage people that we want to get you through that first year. That's why it's 13 months. We want to get you past that anniversary. Because there's going to be so many triggers that come up, there's going to be so many questions, and that's why we work as a team. So that way we can all kind of work together to make sure everybody is getting what they need during the most sensitive and intimate time of their life. The one thing I want to say is, for hospice, we treat your symptoms, not your disease. So when a doctor or a PCP may say, there's nothing more we can do, yeah, there is. That's probably the worst thing that somebody can say to somebody. Oh, there's nothing you can do. Yes, there is. We can treat your symptoms. Okay? We don't take away all, I'm not going to segue into this, I'm sorry. We're not going to take away all your meds. We're not going to tell you what to do. We're not going to replace who you have, meaning your PCP. We have our own provider. We have a hospice physicians, and we have nurse practitioners as well. But we're not going to replace your PCP. Okay? We work with them. They help us sign those plan of cares, and they help to certify the certification of terminal illness. Okay? So we're not going to replace anything. We're not going to take anything away. We supplement what you already have. And the one thing that we always have to remind ourselves too is, under death and dying, we do use real words. We're not going to say, oh, it's time for comfort care. We're not going to say, well, so-and-so when so-and-so passes away. We're going to use those real words because everybody's interpretation is very, very different. Okay? We want you to include the children, the grandchildren, because death and dying is a natural process of life, but there are many times where it's unnatural. Trauma could be something sudden diagnosis. Many times we have patients who have received a diagnosis 2 weeks, and then 2 weeks they're on the decline. Or we could be taking care of children. That's unnatural, right? So there's the thing with hospice is cancer doesn't discriminate. Terminal illness doesn't discriminate. Doesn't matter who you are, what you've done, how much you have, what you don't have. It happens, okay? We do have our volunteer program. We love to have our volunteers. They go through, I think it's a 24-hour training. We do criminal background checks. We're very particular about who we put in the home. We want people to be comfortable with talking about death and dying, okay? People need to talk about it. It's going to happen. And with volunteers, they're able to be there and lend that kind of support, a little bit of respite. If somebody wants to go to the grocery store, if somebody wants to go for a walk, if they want to have the caregiver wants to have a nap, that's the time to have a volunteer there. Let them just be right there. And especially if if the patient can't, if they're unsafe, like if they shouldn't really be trying to get out of bed or whatnot, okay? So under hospice, you don't have to be homebound. Jamie, Christy, and Carrie talked about that. Under hospice, you don't have to. So when I say that if you want to hop a plane to Vegas, you hop a plane to Vegas, because we want you to increase your quality of care. Okay? We have many patients that we work with throughout our state. Our footprint is very large through the entire state of Maine. Okay? We cover Aroostook, but there are many patients from Ellsworth, our Ellsworth office, or Bangor office, that will come up here because they have families who have camps. And then we will cover them. If they have a question or if they have, their symptoms are out of control, we'll come and see them. We'll take care of them. So that's part of why it's so good that we work all together, because a lot of our patients travel up and down the state. Again, you don't have to be homebound. We don't want you to be. We don't want you driving if you're on narcotics. So we're not going to take your license away either. Okay? But we will do some education, and if we have to, tell your PCP, we probably will. Because if it's unsafe, we don't want that, because we all have people that we love on the road. It doesn't mean, enrolling in hospice means you're giving up on living. Nope. You're not giving up hope either, because you always have to redefine what your goals are. And there's always hope to have, okay? I hope that I can see, my grandchildren be born. I hope I can get to the graduation. I hope that my children have peace. I don't want them fighting in front of me. There's always hope, okay? You don't have to leave your home, my home for an inpatient facility or give up my primary care. We just talked about that. Because home is wherever home is that's defined by the family, just like family. We all define our own family members. We have very close neighbors or friends that we do consider to be family. Home is the same thing. Home could be a nursing home, it could be boarding home, it could be assisted living, it could be a tent, it could be a camper. There are many places we have provided hospice care. Sometimes they're maybe not what we would choose, but it's maybe what the patient has. And just like anything, we don't always choose things, situations define what we have. So we have had patients who have lived in garages, hotels, and tents. So the increase in homelessness and for our hospice is on the rise. You can go to the next one. Under hospice, it is covered by your Medicare, main care, private insurances, VA, and we also have patients who do not have insurance. They get the same care, okay? So we work within whatever your insurance is. Hospice is covered under your Medicare Part A, and same thing with the main care and the other insurances. What we don't cover is if you have a private insurance, we're not going to pay your out-of-pocket or your deductible, okay? But we go with whatever your insurance covers, okay? But if you do not have insurance, we do have patients that we still provide care to, because they deserve the care just like anybody else. Hospice is usually associated with somebody who has cancer, but we cover, it's all whatever the PCP says. If the primary care provider says somebody has a terminal diagnosis and a prognosis of 6 months or less, but they have COPD, they have any type of respiratory, they have had a stroke,
Neurological, like Parkinson's, yep, there's that. Obviously the cancers, Alzheimer's, HIV, whatever that PCP says, okay? Hospice, palliative care, and comfort care are similar, but they are not the same, okay? A lot of times you're going to hear, or you're going to have a family member who hears from their PCP, well, it's time to have comfort care. Well, what does that mean? Who doesn't want that? We all want to be comfortable, but what does it mean? Okay? That usually means that somebody doesn't want to be back and forth to the hospital anymore. They really don't want a whole lot of interventions. But is it hospice? No. Because you can have comfort care, go home, or you can stay in the hospital. But if you go home and you're on a skilled care, you have to be homebound. Palliative care is somebody who's also receiving treatment for something. They're receiving aggressive treatment, but they don't have that prognosis of 6 months or less. That's a couple of the biggest issues right there. So palliative care, they do have a life-limiting illness. They just don't have that prognosis of 6 months or less. And they can still continue with chemo or radiation, dialysis, immunotherapy, hydration, paracentesis, thoracentesis, things like that, okay? Under hospice, it's for people who are no longer seeking that aggressive treatment, okay? There may not be any cure, but again, that's where we go back to treating the symptoms. All hospice providers are pretty much the same. We all work very differently.
Everybody has they're not the same, but they have that similar approach. They believe in the hospice concept, they believe in the philosophy. Everybody works a little bit differently. We're a nonprofit. We are not for profit. If it's not my, this is my favorite. I'm not even going by this. Don't trust that your provider is going to talk to you about when it's time for hospice. Usually, when people think hospice, they think you're in the last hours or the last days. Kind of like the whole topic of death and dying. Did we ever think about that? That's usually one of those taboo subjects that we're always. Nobody's going to sit around and talk at the coffee shop and probably talk about death and dying. It just doesn't usually happen. So don't think your provider's going to do that. And I'm going to give you an example of what happened. I did receive a request for an informing. Informings are free. It's just information that you're going to be getting from us about what your options are, of what hospice is. Okay? You really don't need a doctor's order for it. It doesn't cost you anything. It's just information. Everybody deserves to have information to make the choices that they want at the time that they need it. For hospice, like I said, we provide it in any place that you determine to be home, okay? But we can't be with you 24/7. That's another myth that's out there. We're available 24/7 because just like home care, just like home health, there's that 1-800 number you can call. Because we all know that emergencies and issues do not happen Monday through Friday, 9 to 5. Never. We may get the 11 o'clock at night phone call of, I haven't pooped in 4 days. Nobody wants that either. But there's somebody that's going to triage that. If there is a need, there's uncontrolled pain, or there's something that's going on, if you're a caregiver and you're nervous, say, I need somebody to visit. Something is wrong with my loved one. That nurse will come, okay? They're not going to be able to stay all night, but they're going to come and help assess what is happening. They're going to try to triage it. Did they have their medications? Did they fall? Tell me what's happening. So they know what they're dealing with to give you some information over the phone to help you during the time before they get there. Okay? So again, we can't be there 24/7, but we're available 24/7. I know we talked about it earlier today with just us four. The question may come up about death with dignity. Under our Northern Light umbrella, we don't promote that. That is real. It's a law now. People can make that choice. We don't make your referrals. We do not make your phone calls. We do not prescribe your medications, and we will not sign. But if you are somebody, or if a patient has that already in place, we can still provide hospice to them, okay? But we're not going to give them the meds. We're not going to support, it's kind of like the marijuana. A lot of people are doing that with the gummies, or they're smoking marijuana. We don't give you orders for that either, okay? That's just a choice. You go to your regular provider for that. But under Death with Dignity, we will support the patient and the family during that time. What has to happen is, if that's already in motion, if we're in the home and the patient says, today's the day, I'm going to take these meds, we exit the house, we stop our visit, and then we come back in after they've taken them. And we can support the family. That comes very hard because that may not be our goal and not our value, but we have to support the patient where they're at and what their decisions are. So we don't encourage that. If they ask us questions, we have them call their PCP. Okay? So that's a Northern Light stand that we have made. We do work together. We talked about that. The patient is at the center. They are the ones that are driving this bus. And there's many times where patients and the families, they're not on the same page. Okay? There's those myths about morphine. Oh my God, they're giving me morphine. That means I must be in my last hours. We've had patients on morphine for a long time. We don't believe in snowing people. We want people to be as independent and as comfortable as they choose to be. So when I talk about the dynamics of families, there's a lot of times family members, they want their loved one to have more meds, but the patient wants to be more alert because they want to capture every moment that they can. Because they know if I take certain medications, and we only add those medications when it's necessary. We have patients with no meds. That's fabulous. We don't take them away either. What we do is we look at the meds, the nurses will look at the meds, and they'll do like a reconcile. They'll look at them, find out what's needed, what's not needed. They'll talk with our provider and find out what they really need to have or what they really should have. But they can get rid of like cholesterol meds, or they can get rid of the vitamins, things like that. But again, do we take them away? We do not. We just make recommendations. That comes down to patient choice. We've actually had patients who have improved because we've suggested that they stop some meds, and they've actually done that. So we've actually had patients get better to the point of they graduated and we had to discharge them because they were no longer declining. Medicare says we have to show a decline. We had one in particular, I've been doing this for like, well, a few years. Two are actually, they weren't kicked out of the nursing home, but they no longer qualified for the nursing home. So not only did they be discharged from hospice because they improved from the nursing home and had to go back home. Okay? That happens. Patients can choose. If they're on hospice today, they may say, no. In a couple weeks, they may say, I don't want hospice anymore. I want to go get treatment. Or I want to know if that doctor lied because he said 2 weeks, and this is week 3. We've actually had somebody cross off the letters on the calendar. Very sad. So they terminated their hospice benefit, went and had their test, and found out that not only did their tumor get bigger, it kind of spread. Okay? So we always tell people, if you want to go to the hospital, and if you want to have those testings and whatnot, what are you going to do with that information? Because then we have to start back to square one. We don't tell them that, but that's usually what happens. Okay? But that's their choice. And it's their choice to come back to hospice if they choose to. Under Medicare, you don't have any, or whatever insurance it is, doesn't really matter. You don't have, it's not a time frame. You came back to hospice twice, that's it. Nope. We've had people come back. What we do on the 3rd time, we begin a referral from them, then we really look at and talk about what their goals are. Okay? Do you really want to be on hospice? What are your goals? What do you think is going to be different this time? So we do have those tough conversations with them. For a hospice, I want to see those. We talk about the plan of care. It's not our plan of care, it's the patient's plan of care. It's the same as home health. Okay? We talk about what they want to do. And it's more, the reason why we work as a team is because hospice, we're talking about the physical, the emotional, the mental, the spiritual. That's why we have all the team members. Because there's many times that, a patient we may think they're in pain, but what type of pain is it really? Okay? It's very hard to medicate emotional pain or spiritual pain. And so that's why we do have those difficult discussions. They may be not having any physical pain, but they are really struggling with the things that they have, either the choices that they have made. And some really feel, based on their belief, but some of them feel that they have wronged people in the past, so they deserve to be in pain. And that's a really hard thing to navigate. It's really hard a lot with working with veterans because they've seen a lot. And so we try to understand that. And so those are the things where it becomes very hard, because sometimes families will think, well, they're in pain and you're not doing anything about it. Well, we have to look at what type of pain are we talking about. You'd be surprised the amount of people that refuse to have our chaplain or refuse to go to church or even talk about it. and may have been very involved in the church years ago. It's just a balance. We just have to work with them and see what we can do to help bring them comfort. Because when people think hospice, they think, oh, it's going to be pain. Oh, you're dealing with morphine. There's plenty of meds that people have that have been prescribed by their provider that are way stronger than morphine. And that's a real aha moment for the patients and families. They're thinking, well, what do you mean? Well, this med over here is like 10 times stronger. So that's why we do a lot of education with the families and a lot with the patients and the families. Families, I'm not going to lie, you make it very hard. And we always say, of course I'm a social worker, so there's always a seagull in the family. Everybody's got one. It's that person, whether or not it's a family member by blood or a neighbor or whoever, they always swoop in, poop, and leave. Okay? And what I mean by that is they're not always actively involved, but when they come to visit, they kind of stir the pot. You should be doing this. How come? Oh my God. How come they're in their jammies? They were never in their jammies before. They've lost so much weight. Why are you not feeding them? And you're thinking, I'm doing the best I can. You haven't been here in 3 months. Things are going to change. You've been gone. You're a snowbird. You came back. And then, my father's had, chemo and treatment. A lot of physical changes. Those are the ones that really we struggle with, but you know what? Every family has one. I have at least one, if not two, because they're always telling you what to do, what you should do. When sometimes you're just hanging on by a thread because you're doing the best that you can with what you have in the moment. Because it's not just the physical part that's very exhausting being a caregiver, but it's your mental state too. Because you're being a caregiver, but you're also trying to be the daughter or you're trying to be the spouse. And that's under hospice, that's where we can really help you with that. We do have the ability to provide respite, and that's a 5-day respite in a contracted facility. That gives the caregiver a break. That happens a lot.
Who are the contracted facilities in the area now?
We have, let's just say, we have every facility but one nursing home in Care-Hospice.
Whether it's what?
One nursing home in Care-Hospice.
Okay.
So we have contracts, I think, in almost every other facility. That one, okay, so might be that one. So, but the big thing with that is if it's a contracted, say it's a nursing home, we're not probably going to find a bed because there are limited beds. But we also have our House of Comfort. And I'm going to get into the House of Comfort I'm going to put my other hat on at that point. So, but that gives the caregiver a break. So there's many times where we don't want you to miss those milestones, like graduation's coming up. Maybe your patient has to be home. Nobody can leave them. You might have confusion. They may be trying to get up, but they forget they can't drive, so they're trying to drive. Or just maybe they just need 24/7 care. And you are tired, but you don't have anybody to watch them or stay with them so that you can attend a graduation or see a grandbaby being born or take a walk
Or just get
or
rest.
get rest. Yeah. If you can't leave your house, who's getting your groceries, who's paying your bills, and what? Are you able to get to church? Watching it on TV is not the same as being in person. Okay? People say you don't need a building to have the spiritual support, but that is extremely important for a lot of people. It's that connection and the feel of being in church. It's different. So we want you to be able to do that and experience that and fill your cup. Okay? Oh, wow, we talked about that a while ago.
I was going to say, let's get that.
Oh, yeah, the fun part is, this is another one. I think it's fun. Just because you may be eligible for hospice, you have to accept it. Or there's times where we call and we make an appointment to go talk about hospice or do an admission, and then we're greeted at the door by a spouse or a family member saying, don't say hospice. What do you want me to say? No, we're not going to do that. We've also had families will say, well, they have a dementia. They're not going to remember anyway, so don't say it. I'm like, no, we don't care. It's patient rights. They deserve to know. If they forget, they forget. But I'm not going to pretend I'm somebody I'm not. Okay? So they have the right to know. And they have to accept services. There are times where we can't provide hospice services in a home, and it could be for safety reasons. And that goes for home health as well. Most common level of care is routine level of care, and that's care that's provided in the home or home-like setting. We talked about respite. That's the 5-day in a contracted facility. And there's another level of care, which is GIP. And that one is when the pain is, we can't seem to manage the pain at home. And it's not just pain, it could be symptoms. It could be uncontrolled vomiting or restlessness or whatnot. So there's things like that, and we've tried, we've made changes. That means that we can bring the patient into our house of comfort and provide that more high-level, intense care that the patient needs. And most of the times that means that patient is probably transitioning in their journey. And I did forget to mention under hospice, we do cover the medical equipment, which is a hospital bed, walker, commode, bedside commode, transfer bench, wheelchair, things like that. We cover that, and that comes out of our pocket. Okay? Hospice is not a money-making adventure. We get a very small pot of money per day per patient. But out of that very small pot of money, we pay for all our DME, hospital bed, oxygen, things like that. Hospital bed alone is like almost $250, $300 a month. So you can multiply all of that and medications and whatnot. We pay for supplies. So if somebody need a TENS, wound supplies, ostomy, things like that. So we cover those. We cover whatever is related to the diagnosis that hospice accepts. Okay? And when you sit there and you look at, anytime you've gone to the hospital, it doesn't matter who you are. Many times you've been to the hospital or your doctor's office, you're going to have a whole list of diagnoses because they like those. So when we look at that under hospice, we look at, and it's with the PCP and our hospice doc, we look at what is the diagnosis that's considered to be terminal or collection of and comorbidities that is going to be the reason that this patient dies. Kind of morbid, but that's how that goes. And what we do is we pay for the medications that are related to that. So if somebody still wants to take their vitamins and all of that, you can do that. We may not cover it, but you can still do it. You can still get it the way you normally do. Okay? It just comes down to two choices. I'll just put those away. The right time is when I had talked about, if you're noticing somebody who is back and forth to the hospital, they're losing weight, they have a change in their cognition, falls, they're using those key words to you. I'm tired. Okay? And when you talk about that, when you think about that, you're seeing your loved one decline. And if you want the information, we'll give you the information. But we do need that referral from the doctor because they're going to sign on the dotted line. Yes, I do believe that my patient is terminal with a prognosis of 6 months or less. Okay? But information is free. We want you to have that. So we can talk about that. You may be physically ready, but you may not be mentally. And that is a big decision. It's a good thing to get your family involved in talking about that too, because we do talk about that. We talk about power of attorney. We talk about advanced directives. Everybody should have one. I remember years ago when I first started as a social worker, and I was talking to a patient about advanced directives, and they're like, "Do you have one?" And I'm like, "No." It was my aha moment. I did get one. I was in my early 30s. It was the best thing because you want somebody you want to designate somebody that you trust to make your decision. Same thing as a power of attorney. And you got to make sure that they're on the same page. If you're thinking all your kids are going to be on the same page, that's probably not the case. You need to have those discussions because a lot of times we have that because families can be barriers. And when I say families, I mean who you define as family. But when you have those advanced directives and those power of attorneys, you want someone to support your decision and follow through with your decision when you cannot make that decision on your own. And the reason I say that, and I'll use my own family because I'm not talking about anybody, it's my baggage. I don't have my parents anymore. My mother died when I was very young, and so my father pretty much raised me along with, well, some step monsters we won't talk about, but that's my dynamic. So he did have an advanced directive. He was under a dialysis. He had a lot of health issues. And when it came down to the time when he had his final heart attack, it wasn't fatal at that time, we were glad his advanced directive made that choice for us. Because when it comes down to it, your head and your heart tell you two different things, okay? And that's not the time to be iffy. We knew he didn't want to be on life support. We knew that. And would we come together as a family? Absolutely we would have. But he took that decision away from us, which was fabulous. Because our heart was saying, this was our father. He was our only parent left. Was it hard? Absolutely. It was emotional. Okay? So very important to have that as well. And when I get down, when I want to talk, I've missed the whole part about talking about family dynamics. There are two types of families. There's open family systems and there's closed family systems. And what I mean by that is open family systems are very open. They talk about everything. They're open with affection. They're open with any type of discussion. Closed family are the ones that are like, nope, not going to air my dirty laundry out. That's my stuff. Neighbors don't need to know. Not going to talk about it. Nope, not going to talk about death and dying because that's not going to happen. I grew up in the closed family system, okay? I did not know my mother was sick. I was 8, but I didn't. Of course, when you're 8, you don't know if you're foot or horse or not. But it was that time frame where I go out and play, okay? So I didn't know. My dad didn't talk about it. It was too hard to talk about, okay? So that's a whole other issue. I mean, that's just with anybody. We want people to talk about what's going on in their life because we only have one chance to do this right. You only have one chance to die right and die well. That's why we use the words. Because when my father told me that my mother had died, he had said, your mother's not coming home. I did not know what that meant. I was 8, I didn't know what it meant. So that night I asked my sister, I said, Marilyn, I said, why is Mom not coming home? She said, Gail, Mom died today. I understood that. So never underestimate children, okay? My whole life I feared death, and here I am in hospice, okay? But use those conversations. Children, they need to know, they need to understand. Can you just think, I have grandchildren. If I was lying on my deathbed, I wouldn't want them to stay away from me. It's part of the process. Is it hard? Absolutely. But that's where you want your family to be involved and also support your decisions. There's many times where we have families that are divided. You're giving too much medication. No, you're not. Yes, you are. No, you're not. And there's a lot of turmoil. Okay? The other thing is don't make promises you cannot keep. Families do that for the right reasons. I promise you're not going to have to go to a nursing home. You can't make those promises. You want to, but you can't. Because when we are dealing with patients who are dying and they're very active, they're restless, they might be up for days at a time, no resting, that caregiver's exhausted. They can't make those promises anymore. Then they're feeling guilty because they made a promise that they can't keep, okay? The other thing is I promised I would hold his hand when they die. They're not going to die alone. That goes back to the type of family. My father we were all around him in the hospital. We left for 3 minutes. And he died. That's the way he wanted to be. because he was, whether or not he was protecting us, we were adults, but he might have been protecting us. But he was in charge of that. People die as they live. He was a very, very private man. And he probably wanted to die that way. Okay? Does that make sense? Clear as mud?
Go over the house.
Where's the house?
Whoa, good job.
Right here, this is where the house.
Okay, here goes my hat. So, the Aroostook Hospice Foundation, they created the Aroostook House of Comfort, okay? That is our beautiful building that is in Presque Isle. And that came to life, that idea came to life in 2009. We opened in 2018. That's how long that journey was to make that beautiful building, okay? And the reason behind that is because Rick Duncan had his mother under hospice. And she had a very terrible disease, very terrible cancer, that back in the day, we had to contract with hospitals for GIP to get people under control. And what happened is the hospitalists were changing all the time, and none of them were educated and trained in hospice and end of life. They didn't understand the medications. So as we were trying to have increases in meds, they were not listening to us. So what happened is the Duncan family ended up sleeping at the hospital for 28 days. Maxine was in the hospital. And they had to advocate along with us. We had to advocate every day about changes. We were called Dr. Kevorkian because nobody understood the amount of medications that some people need to make them comfortable. Not speed up the death, but to make them comfortable. What was happening is they would just give a little bit, give a little bit. But what happened is she was so much in pain, she needed to have a larger dose and then pull it back some. And that's what happened. The day she died is when the Duncans said, there's got to be a different way. We've got to have a hospice house. And that idea kind of escalated into, that's how they took their vacations. They didn't take vacations in the Bahamas or anything. They went looking at hospice houses across the United States. They took pictures of every build that they were allowed to. They took pictures of the kitchens, the ceilings, everything. They wanted to mold their building to be as beautiful as what his mother was deserved to have. And so what happened was they did the fundraising adventure. They did tons of fundraising along the way. So that when they found this building, which was a call center in Presque Isle, they found an architect with all of their pictures that they have compiled over the years along with their fundraising. I want this for a ceiling, because if I'm laying in that bed, I don't want to see tiles. I want to see a beautiful wood. I want to have this for the living room. And so they put their dream on paper and had an architect make a homely building homey. And that's exactly what they did. So we have a 6-bed unit. Each suite has their own room, their own bathroom, and their own kitchenette. Okay? It is specifically designed for getting pain and symptom under control. Yes, you have to be a hospice patient, but it's for that high level of care, and most times patients don't need it. Sometimes we can get their symptoms under control, but when we get their symptoms under control, then they're able to discharge back home, or to a nursing home, or a home-like setting, or a family home. There are many times where patients will die with us. Okay? Medicare does not cover this is the sad part. Medicare will not cover a patient at that high level of care to die comfortably under that high level of care. I'm like, well, they're actively dying. Medicare's like, what are you doing to control? You know, because what they say is that that high level of care takes oversight of a physician and ongoing nursing assessment that cannot be done in a home-like setting. okay? It's very complicated. We deal with it all the time. But if a patient, it comes to us, we can get them controlled. They have their beautiful suite. Yes, people can spend the night. There's a little area where people can sleep. Families can sleep. Yes, it's on like a sleeper sofa, so we want you to be comfortable. We do have a chapel. And the chapel is, the stained glass was donated by St. Patrick's in Portland. And when the House of Comfort was being designed, it had the opening for beautiful stained glass. Unfortunately, that was 3 times the size of the opening that they had. So the foundation, which is a group of people, board members that spearheaded this building to be and all the fundraising and whatnot. That's why we call them the foundation. They went to St. Patrick's, yeah, we're going to talk about that again, and asked for permission to alter the stained glass without taking away the beauty. And right there is like a panoramic view. So it did change it, but it didn't take away the beauty of it. So in our chapel, it's on 3 walls. And before we opened in April, of May, we received our license in 2018. The bishop came to bless our building in April, and it was April 6th. So that was very important for us. It was very important for the Duncans. We needed to have that because it's a very trying time for a lot of patients, but it's also a very trying time for our staff as well, because we walk this journey with them. We have a living room and kitchen. We have a big, beautiful kitchen, but we also cook for patients too. We used to have the food contracted through A.R. Gould, but we found that it was a lot of waste. And because a lot of the times the patients will come to us and they're not eating. But when the patients come respite, they can eat.
So Rick makes cookies.
And Rick makes cookies. So we want them to eat. So, and it's like we tell family members is, please don't tell your loved one what they can and cannot have to eat. Let them have something. We had one person just live on Kit Kats. Great. Who doesn't want to go buy a Kit Kat? It's your journey. You are driving that bus. So if you are not supposed to have salt and you want salt on a big red steak, you take it. That is up to you. Okay? So that's the other thing. People think that we take away your meds and we take away your food. We don't do that.
What about treating an alcoholic? They request things like alcohol.
We can do alcohol. That is our doctor's order. And the alcohol is in our bedroom. It's locked up. We don't provide it. The families will bring it in, and it's locked up, and it is a doctor's order. So we do have that. And I'm glad you mentioned that, because we do deal with a lot of patients who have struggled with abuse in the past, whether or not it's substance or drugs, or whether or not it's alcohol. Sometimes it can be very hard to medicate because their threshold may be very different than ours, and that's okay. But that's not the time to say, gee, I don't want them to become addicted. We do get that, because we have a lot of families that will say, no, they can't have morphine, they can't have oxycodone. No, they're going to become addicted. So there's a lot of education with our providers, with the families saying, you know what, they're not.
What about smoking?
At our House of Comfort, we don't allow the smoking. Because, it's and there's no marijuana. We don't do the death with dignity there. That's a no-go. That's a stance that we made for the House of Comfort. Because it doesn't follow the laws of the death with dignity. Because of death with dignity, you have to be able to take your own meds, and all our meds are locked in the med room, and we have to be bringing it if we don't do that. It's a vision that with the foundation that they didn't want that either, so we help support that as well. We do offer a nicotine patch. We can offer that as well. Okay? We have to tell them Logan's room. Logan's room is a toy room where children can go, because like I said, we always want the children involved. There's nothing more healing and therapeutic than a children's laughter. And we want them to have that. We want their lives to be as real as it possibly can in such an unnatural moment at times, but we want them to be involved. And Logan's room is named after Logan Grave. At the Graves grocery store in Presque Isle, the owners, Bob and Lynn, they had, when Logan had died, they had this fundraiser for the golf tournament. And they had that for years, and they raised an enormous amount of money. So when the foundation built the hospice house, the House of Comfort, they turned over that golf tournament to the foundation. And so Logan's room is dedicated to him. We have the living room, and when patients come to the House of Comfort, we never know what kind of journey they're going to have. I mean, we may think, well, we're going to get their symptoms controlled, they're going to go home. Sometimes it doesn't happen. You know, maybe they find peace with themselves. And it's not the morphine or the medications that causes the death. The medications allow them to relax because it's the disease that's the cause. So we do get that. Because there's always going to be one dose. There's always going to be a last dose. And that's what families have said too. Or I can't give them the morphine because I don't want to be the last one to give them the dose. Well, there's always going to be a last dose. We just don't know what it is. It may not be morphine. It might be something else. Okay? Everybody gets a private bathroom in their suite. Like I said, we're only 6, so we're not a residency. So we've had many families say, I don't want my loved one in the nursing home anymore. I want them to go to the House of Comfort. Well, because we're only 6 beds. It's not a nursing home where main care can pay the room and board. It's designed for short-term care for patients to get their pain and symptoms under control and so that they can transition homeward to a nursing home. If their pain is under control and we have a good guesstimate that this may not be long, we will keep them with us. We've learned a few things along the way because we have discharged people before, comfortable, back home with hospice, and then they died. Because nobody has that crystal ball. We didn't know. But now that we've been doing this for 6 years now, we're like, oh, this patient, I don't think they're going to, the transport's not going to be good for them. And I don't think we have long, so we're going to keep them with us. But that's, again, patient, we don't make that decision. We suggest it, and then we have the families agree to that. That's the time for the families to come in and be a family, where you're not being the caregiver. Okay? That's what makes our House of Comfort so unique. It's the 4th one in the state, and it's the only one in Aroostook. And we have taken patients as far away as Standish, Maine, to the Allagash. And there's a lot that we take care of in the St. John Valley.
Do you charge?
The House of Comfort, it depends on okay, I'm just going to be yes and no. How's that? Medicare covers that high level of care of GIP. It covers respite. And it covers routine. We have had patients come to us routine because either they lost their caregiver or it was homelessness or something. But we knew that their prognosis was not going to, we weren't going to have them for months. So if they come to us routine, like it's the same level of care as they wouldn't be in a nursing home or in a home, but they have no place to go. If we know it's not going to be a long period of time, they can pay for the room and board, which is $415 a day. That is costly. It's very similar to what a nursing home would be. Or we can have them apply for charity care. Okay? So the foundation has a charity care program and Northern Light has a charity care program. So together we will make sure that that family does not have to pay if they do not have the means to do so. Main care doesn't cover the room and board. Insurances don't cover the room and board. What Medicare does is it covers the level of care. Okay? Our gazebo, we have our beautiful gazebo up there. It has electricity, and that's where we have our memorial service every year. We dedicate a ceremony to all those that have died under hospice within a certain time frame, usually within the year, and also those we provide courtesy bereavement to. So home health may have some patients who die under home health because they weren't quite ready for hospice. but we provide their families with bereavement follow-up. So that's phone calls, that's mailings, that could be a visit, and we also have grief support groups in Presque Isle. But if we had the desire or the request, we would be doing it here in the Valley as well. Okay? And the Memorial Garden is, what the foundation has is, we call it Remembrance Way. And that is a dedication to stones where families, they can purchase a stone. And every August, there's a dedication to that. And you can put whatever saying you want on it. No, you don't have to have your loved one die at the House of Comfort, because I have my parents on one. Okay? My parents were under hospice. And that's a ceremony that's, there's the stones in the Memorial Garden. You can have whatever you want on it. You can have a big stone, small stone. Some people have they want to purchase like a garden, and they have a dedication in regards to a garden, or they can have a bench. Those stones, the purchase of those stones, that's a fundraiser to help support the foundation and to have the House of Comfort. So when people think hospice and the House of Comfort, we are very similar. We work very close. The House of Comfort is owned by the Hospice Foundation, and hospice is Northern Light. We staff it. It's our medications, our equipment, our supplies, and the foundation is the building. And by the building, I mean it's our beautiful home. Okay?
So the people who work in the building are Northern Light employees?
Correct. Yep. That's why there's a lot of confusion in the because it's different but the same. I mean, they have the hospice house, but you need hospice to run it. And so that's why we work very well as a team, and that's why we do things we collaborate a lot together. Okay?
Do you have a physician on staff from Northern Light that will visit in your comfort home?
We have several.
Or they have to be connected to the individual patient that they have.
They are our physicians. There are. We have Dr. O'Neill. We had Dr. Jones.
Yeah.
And I still say we have Dr. Jones because he's hidden in my heart always. Dr. Flynn, Carl Flynn from Pines Carey. He's employed by us as well. Not full time. He's per diem. Dr. Shaw, who was with the VA for several years, over 20 years. He works with us as well. And we have nurse practitioners. And we have Jamie St. Peter. She's a nurse practitioner who works at TAMIC full-time or AR Gould full-time. So she works with us per diem. And we also have Catherine Raymond. She's a nurse practitioner who actually left AR Gould to come to us full-time. And we have another nurse practitioner that we recently hired who's starting in September 1st. So yes, our providers are with us, and they round daily. Yep, and they're available 24/7. So if there's any issues, because we all know, Aroostook County, nothing happens Monday through Friday, 9 to 5, we can call them up. We get orders over the phone, we make changes. For patients in the home, there's medications in the home that we provide that gets drop shipped. We don't deliver meds, we don't pick them up at the pharmacy. We can do local fills so families can go to the pharmacy. We have a comfort pack that goes in the home as well. If it never gets used, it never gets used. But the comfort pack is designed with a little bit of everything in case of an emergency. Okay? Because there's no 24/7 pharmacy in Aroostook County. And when people get discharged from Maine Med or Boston or Bangor, by the time they get home, pharmacies most often are closed. So we want those meds filled before they get in that ambulance to come home. And we have a med room, our own med room at the House of Comfort. And if one of our home patients needs a med, that doesn't mean we can take it from our med room because we're not a pharmacy. Okay? Those are the amount of people that we, and that's more than what we've had, people that we have served at the House of Comfort. That is not hospice in general, that is at the House of Comfort. So those patients that have come to the house, that's the number of people that we have served in the towns.
Do you foresee another House of Comfort in the future in Aroostook County? Because we are a big county and we have a lot of elderly people.
I don't know. There's usually a feasibility study that has to happen. You don't make money on that. We lose money every year. I mean, I'm talking big money. Because It's the right thing to do for the community. It's an entitlement that people should have because Medicare, main care insurances. It would be nice if we had another one.
But if there's a big need out there.
Yeah, there is.
When the
Yeah.
median age of Aroostook County is 48 or 49 years old, so.
Yeah.
We are all baby boomers, we are baby boomers in this room, so there'll be a lot more people that want a bed in the near future.
You know, when you think of that, you're right. We're an aging community, and we know people are dying left and right. All we do is look at the paper. Okay. With that in mind, there are more people that should be on hospice or should be entitled or offered to hospice, but they're not. That's why we're doing things like this, so that you can be your advocate. You think of how many people we have in Aroostook County, because, like I said, terminal illness does not discriminate. Doesn't care how old you are, or how young you are, or what you've done, what you have, what you don't have. Okay? Our census today was 39. That's not a lot. That is not a lot when you sit there and you look at the big picture.
Hospice patients.
Hospice patients. That is not a big number. Okay? So there are a lot of people out there that really could benefit from hospice because, again, it's supplementing what you already have. You're entitled to this. This is what you worked for. This is your Medicare benefit or your main care benefit or whatever you have for insurance. So be your advocate. Be your friend's advocate or your relative's advocate. Okay? Ooh, I went over. Any other questions?
Very well done.
Gail and Christy and Jane and Carrie, thank you for spending your time with us this evening. This is our last class, and it's a good one to end with. And I invite everyone to keep an eye out for the new bulletin that will be coming out for the classes beginning in the fall. We have a lot of amazing just topics that are going to be coming up, and I hope that you will join us again. Again, thank you. And, thank you.